Welcome to Plastico Review. Let's go through the latest papers of aesthetic plastic surgery of the breast for the month of March. And we'll begin with a paper by none other than the editor of the cosmetic section of PRS, David Hidalgo, and also Andrew Weinstein, where they do an intraoperative comparison of round versus shaped implants in breast augmentation and performed a randomized controlled trial. Now, this is one more of the several papers we've been talking about where there's a comparison between round and shaped implants in order to try and determine if there's any difference or an aesthetic improvement of the shaped devices over the round ones. The latest one being the Spanish paper by Carlos Rubí and Jose Angel Lozano from the beginning of the year in PRS, which had an excellent discussion by Frank Lista. Now, the difference with this paper is that it is a level 1 study. It's a randomized controlled trial. So what David Hidalgo has done is that he studied 75 patients undergoing breast augmentation, and intraoperatively, he placed a round implant on one breast and an anatomically shaped implant on the contralateral breast. And he took pictures with the patient sitting up, and those pictures were evaluated by a group of 10 plastic surgeons and a group of lay individuals. Afterwards, a survey was passed to each of the two groups in order to determine if they saw any differences between either breast or if they considered one of the sides aesthetically more pleasing than the other. And the results were very conclusive. Over 1/3 of the individuals of both groups were not able to determine any difference between each side. Furthermore, when they were able to notice a difference between either side, there were no significant differences in terms of the aesthetic improvement of shaped versus round implants or vice versa. So the conclusion by David Hidalgo and Weinstein is that given the disadvantages of shaped implants and considering they're not aesthetically superior to round implants, they question the need to use anatomic implants at all for aesthetic breast augmentation. Now, there are two discussions of this paper. The first one is by Yamil Ahmad and Frank Lista from Canada, and they praise, of course, the high level of evidence of this study, which is really not usual in plastic surgery literature. And they do mention what happened also in the aesthetic meeting of ASAPS 2014, where 20 before and after pictures of both shaped and round breast augmentation procedures from 9 different plastic surgeons were shown to an audience of 305 plastic surgeons. And through the automated response system of the meeting, only 49% of the surgeons were able to identify the correct implant. Agreeing with the authors of the paper, that's really very hard to tell the difference between anatomic and round implants in breast augmentation patients. Now, the other discussion is very interesting. It's by Patrick Malucci. He's an excellent, really excellent plastic surgeon from London. He has published extensively on the ideal breast shape with very, very important and worthwhile papers. And in his discussion, he attempts to defend what seems to be very hard to do after such a high impact level of evidence paper by David Hidalgo. Now, he basically uses 3 arguments to defend his position. His first comment is that the paper is not really a level 1 study because it's not truly controlled. He argues that each breast is different. And although this is true, David Hidalgo did really have very, very strict criteria to avoid patients with asymmetry in his study. I was even surprised by the strict exclusion criteria of his study. He only included patients with less than a 25 gram difference between breasts and with a difference in height between nipple areola complexes of less than 1 centimeter and with differences in the diameter of the areola of less than 0.5 centimeters. So really, that is very, very strict. Most women have larger asymmetries than this. So really, I think that argument in this case was very well controlled by David Hidalgo, and definitely level 1 evidence. I mean, if we were so strict with this, no study could be really controlled, because even if you do a study in a laboratory with rats, no rat is exactly the same as the other one genetically or whatever. So really there would be no level 1 studies at all. Now, the next argument I heard before around meetings, especially here around Europe, and it's about the learning curve. Now, the argument here is that in Europe, these devices, the shape devices, have been around for many years. They've been around since the early 90s, and in the US, they've been only available since 2012. Patrick Malucci says that these devices have a learning curve, and why should Americans abandon the use of shaped implants at the start of their journey or their learning curve? Now, really, I understand there is a learning curve, but I mean, to be honest, using shaped implants, it's really not rocket science, and American surgeons are pretty good surgeons. They have very good training, and it's already been 5 years since 2012, and they're not catching up in the US. Still, the market in the US is nearly 90% smooth round versus shaped implants. I understand there is a learning curve, but really, I was using shaped implants here in Europe when I was a resident in the late 90s. And it's really not that difficult. And actually, other products that were also available in Europe before the US, like fillers, hyaluronic acid, Restylane, which was approved by the FDA several years after it was available here in Europe. And it was adopted immediately by American surgeons because it worked, and this has not happened with shaped implants. American surgeons are skilled surgeons, and the use of shaped implants is not really such a difficult procedure to learn. They don't see that their use is providing so much benefit to their patients. And the last argument by Patrick Malucci is to say that why look back to the one-dimensional volumetric approach of round implants instead of looking forward to the use of shaped devices. Now, this I really can't agree with, because not everything that is new is always better. And of course, an example, you can cut through skin with laser, but still the surgical blade made of steel, works. It just works. So why should we all be using, laser to initiate our incisions when the good old, 15 or 10 blade made out of steel just works fine? Now, of course, there are maybe some indications for the use of more modern technology. Maybe in the future we won't use surgical blades made out of steel to cut through skin. But, for now, if it works, why change it? And, the same thing with what Patrick Malucci refers to as the one-dimensional volumetric, world of round implant augmentation. If skilled surgeons like David Hidalgo have been using these devices for many years and they get excellent results with them, why should they be using any other, three-dimensional method of breast augmentation? That's it for this very, very interesting read, both the paper by David Hidalgo, the discussion by Malami and Frank Lista, and this discussion by Patrick Malucci, who's, an excellent, very, very, very good plastic surgeon with breakthrough ideas about what the aesthetic and the ideal breast shape should be. So, at the end, just have your own opinion and certainly do what you believe is best for your patients. Now, another very interesting read in this month of March in PRS is actually in the letters section, and it has Patrick Malucci once again as one of the main characters. So the letter is actually from Eric Swanson. We've talked about Eric. He's an excellent plastic surgeon from Kansas City, who's a strong defendant of the scientific plastic surgeon and the use of evidence and science to support aesthetic plastic surgery. And in this letter, he discusses Patrick Malucci's and Bramford's paper on the ICE principle from 2016. And it's an interesting letter with concepts such as upper pole fullness, the height of the nipple areola complex, the 45-55 breast portion of Patrick Malucci and Oliver Bramford are discussed, and the size of implants, whether patients should be talked down on their preferred size or not. All these concepts are discussed in the letter. So I really suggest you read these two letters just to understand more about all these concepts that are very interesting in breast augmentation. Okay, I'm moving on to ASJ. There are some very interesting papers this month of March on aesthetic plastic surgery of the breast. And the first one is a paper on the guidelines for the diagnosis and management of breast implant-associated large cell anaplastic lymphoma. It's written by Mark Clemens, who is probably the plastic surgeon in the world that knows most about anaplastic large cell lymphoma, and he practices in MD Anderson, Houston. And it's co-authored by Stephen Horwitz, who's the hematologist that probably knows most about non-Hodgkin lymphoma right now, and he practices at Memorial Sloan Kettering in New York. And some of the guidelines that the paper discusses is that any symptomatic periprosthetic effusion on implants over 1 year old should be aspirated and screened for CD30 immunohistochemistry and flow cytometry. And of course, it comments on the treatment that normally is only surgery if the lymphoma is localized to the capsule. And it comments on the need of using adjuvant chemotherapy if it's extended to the lymph nodes, and even radiotherapy locally if necessary. It does mention that the vast majority of cases have been found on textured implants, and of course this is in concordance with the recent statement from FDA this month and from the conjoint statement by ASPS and ASAPS at the beginning of the year. Now, interestingly, although the FDA does state that the majority of cases have been in textured implants, it does say that there have been a number of cases also appearing in smooth wall implants. Now, this is very different than what the conjoint statement of the ASPS and ASAPS has declared, where although it does say that these cases have also arisen from smooth wall implants, it is very clear in stating that no case of implant associated large cell anaplastic lymphoma has been derived exclusively from smooth wall implants, since the cases to date that have been on patients with smooth implants had already implants before their smooth wall implants, with many of these patients having had textured implants before, and the rest not really being able to identify which type of implants they had before. None of the patients with smooth implants had not had previous implants before, and there has not been any documented case where a patient that has had ALCL derived from smooth implants had smooth implants before. Now, the next paper is really very interesting. It's by William Adams and colleagues, and it verses on the clinical evaluation of the rotation of shaped implants through high-resolution ultrasound. Now, the conclusions of the paper are very interesting. The first one is that implant rotation is extremely prevalent in patients with shaped implants, up to 25 times more than previously thought. In their study, over 40% of patients with shaped implants had rotation of their device. And the other conclusion is that high-resolution ultrasound is an extremely efficient tool to diagnose many implant-associated problems, such as rotation, seroma, or even rupture. and is also discussed on the commentary of the patient by Bradley Bengston. Really, maybe these ultrasound devices should be a part of every plastic surgeon's consultation to perform an adequate follow-up for our breast augmentation patients. Now, one very interesting concept that this paper brings up is that there's actually a discrepancy between the rotation of shaped devices and the lack of a clinically detectable deformity on the rotated breast implant. In fact, although more than 40% of the patients in the study had an implant rotation either side or both sides, when this data is examined individually per breast, it was found that 27% of shaped devices had rotation. Now, what was considered deviation was a 30% off of midline rotation. When this was examined with more than a 45-degree rotation and deviation from the midline, also 26% of the implants were considered to be rotated. Now, this is very different from the only 5% clinically relevant rotations that were found in the study without the aid of the high-frequency ultrasound. And actually, the authors end up raising a few questions, and I read. This discrepancy leads to the question of why use shaped devices at all if 27% are rotated yet still maintain a natural appearance clinically. Or perhaps we shouldn't be worried about rotation because even when it does occur, it is only clinically detectable 5% of the time. So although shaped devices were developed to provide a more natural breast shape while retaining upper pole fullness, their ultimate utility in light of this new data remains uncertain. And this is also emphasized by Bradley Bengston on the commentary of this paper when he states, "I tell patients and plastic surgeons today that if we are planning to use a shaped device, we should have a very good reason to do so." Again, going back to what we have been talking about on the PRS paper of David Hidalgo this month. But really what I think is very interesting about this paper and commentary is that the use of high definition ultrasound in the office will probably become mainstream for the plastic surgeon in the near future. Now, there's another interesting paper on seroma on ASJ this month, March. It's a British paper by Marcus Forsa and colleagues on the factors influencing early seroma formation in breast augmentation. And it is very well carried out, examining different factors such as BMI, pocket size, age of the patient, and implant size, and how these may or may not influence the rate of seroma. Surprisingly, one of the things they did not study was the surface of the implants and how this impacted the appearance, if not of early seroma. They do mention and reference in the text the friction theory by Elizabeth Hall Finley regarding the onset of late seroma. But it would have been interesting to perhaps examine if texturing had also an impact on early appearance of seroma formation. And finally, the last paper on breast aesthetic surgery of ASJ this month is actually a meta-analysis and a systematic review of the literature on the relationship between obesity and breast reduction complications, where they of course confirm that obesity is related to complications and wound adhesions in breast reduction patients. They reminded me to a similar paper on the relationship between obesity and complications appearing after breast reconstruction patients, which they also showed that it was one of the main factors increasing complication rates for patients undergoing breast reconstruction procedures. So that's all for aesthetic plastic surgery of the breast this month of March. I hope to see you next month on Plastic Art Review. Thank you very much.